You're live. All right, good. Back live. This is Senate Health and Welfare. And we're moving into markup and discussion on three bills that we have before us. The one that we just looked at, which is S-189, and got into a real log jam with that one between AHS and Green Mountain Care Board. And let me just share what I'm thinking. And I think Senator Benson expressed it very well also. And that is, we have a state regionalization transformation process going on with hospitals, and also an inclusion of our community-based services, primary care. So it's all together in what our healthcare and transportation needs in different parts of the state. That work is ongoing. There is data being collected and analysis being done. The goal for the first iteration of that bill is 2028. So the decisions that the board and AHS are trying to make right now is in the middle of change. I honestly agree with them. I don't know how they're doing it. It's in the middle of change. So I do think that we should think about what you'd like to see. But I would think, having the plan in place, say, and reaching out to the end of 28 or 29 and saying, once that plan is in place, then AHS would provide data for decision-making at the board and they would have a recommendation. So that's one. Two, that we would ask between now and whenever anything happens, the next step happens, the 29th step happens, that the board and the agency consider how to have a public process for any service addition and reduction. So how to build that into thinking on both sides, whether it's the plan or whether it's the regulatory process. So that's what I'm thinking though. And if you have other ideas, we can bring them together. But I've been thinking about this for a second. I think we should. And then between now and whenever anything is implemented, that the board and AHS can think about how to improve what needs to be improved. That's where I am at this point, and I know that we'll all be hearing from folks at AHS and their concerns. We'll be hearing from the board. Trying to find a middle ground on this one is going to be difficult.
So, one question on that.
Yeah.
I like your plan because I think it's premature to figure out how this gets into the network when the network hasn't even been developed. But in the interim period, keeping the public notice process, I think, is great. But who is making the decision? Is it Green Mountain Care Board, or is it?
I think there has to be a collaborative process.
Even in that initial.
In that initial, they're going to have to sort it out. I mean, they sorted it out somewhat with Rutland. Wasn't the greatest, but they did identify a need for a public process, and I agree with that. I think the hospitals should come forward with that. Yeah. So let's think about that, and we'll try to give Jen some direction on that. Go ahead.
I mean, to hold the public hearing and just say, yeah, because we know the public's going to hate it.
Yeah.
The question is, how are people that have been receiving that service going to receive it in the future?
Exactly.
I think I understand the hospital wants to close it because they've only got 3 cases a year, but what are the arrangements that have been made to duplicate that? Rutland did say that with their pediatrics.
Are you thinking of having some language like that in the interim, that there will be
there's no plan. I mean, we all know every hospital can't offer dialysis. We all know that we probably don't have enough babies yet, but there's a time factor with delivering babies. And so how far, where are you gonna go? If the service gets cut. Seems that would have to be, the hospital would have to have some responsibility to have a plan
It's part of the public
as
process.
part of the public, to tell the public. The other thing I'm hearing, I learned as part of the closures, is that the entire Mad River Valley does not have a pharmacy. They need to travel to Waterbury. And the plan said they were going to need to travel to Waterbury for their medical
Primary care.
primary care. And the hospital said, well, you've already you get that, you already got to go to Waterbury to get prescription filled. And we're going to offer online prescriptions. Unfortunately, with the mail service in central Vermont, there have been major issues with.
Oh, it's everywhere.
Not, yes.
I can't figure out when we get our mail.
Yeah,
Yeah.
and they're not getting delivered and you can't find them. And the pharmacy can't reissue them because they've sent them. And so that option is not viable.
Well, but everything you're saying is part of the ongoing conversation at AHS and within the transformation process, and how do we cover these things that are going away or missing, or what can we add in that will build a better system? That's the point. No, we
But what do
can't.
we do in the meantime?
Yeah, this is the meantime is, yeah, and I think everybody's thinking about making the vision for the future right now, and we can't do that when we're in the meantime, in the transformation.
I think your approach is a good one, two-tier piece of what happens in the next 3 years, and then once the plan is in place, 29 years, the details for that.
Any other comments? Should we go forward with thinking about this?
Yeah, no, this is nothing for shattering, but I just think Senator Cummings brings up a good point, which is that the public comment or the public hearings are a really great opportunity to educate as well as, get input from folks and hear their concerns,
Mhm,
but also educate them because
mhm.
a lot of folks don't really know what's going on. You can't keep up with everything, even if you're reading all of the various media outlets. But so that is a great opportunity for that.
I agree with you, Senator. I can tell you what every single public meeting is going to be. I can lay it out for you right now.
Okay,
Oh, trust me,
we agree with you.
School redistricting as well.
Yes.
At the usual suspects.
Jenny,
Yeah,
there was another article, I don't know where it popped up, about pharmacies closing.
yes.
I think I've known for years that the online prescription people were going to put our local pharmacies out of business. And it's happening. And people are having to drive long distances to find a pharmacy. I think it was up around high.
And then they get there,
And
it's
they
not
drive
ready, and then they.
per pharmacy, and that's a long way. And online, mail order is proving to be unreliable.
A whole bunch of reasons for that.
That wise.
So,
I have a
There is
historic question.
Canada.
here's a historic question coming up.
Because lots of times as we talk about something put in place
Previous.
previously that John and I may not be aware of, but on this whole planning piece. And I thought about this, brought it up in the discussion. So you get this master plan and it says, here are the services that are supposed to be provided in each of these different hospitals.
That's gonna be involved.
But we know that some services, they're gonna break even on, some they're gonna lose money, and some they're gonna make money on. is if in the whole system, it said you will provide these services, and we know they're losing money. How was that paid for? Was that in the hospital's budget somehow that the Green Mountain Care Board is?
That
approving?
is exactly the point that AHS is making about what the board does. So therein lies the conundrum. That you've got plans here and budget here, decision here, budget here. And does that upset the sustainability plan? So then you've got, so that's why having the data and the analysis between the two is really important. And I don't know how to solve that problem.
But I can see that the answer may be, no, you're still going to have to maintain that service, even though it's a loser from a financial standpoint. I'm just trying to figure out what's the mechanism that makes sure the hospital stays solid.
We're with you. You got it. You just put the nail on the problem. Yeah. Well, anyway, so there are a lot of questions that need to be asked in the interim, and we're going to put a dent in this little can. We're gonna try, I think if we can just push the final decision making out a little bit as the plan is being developed, and who has the data and how it will be shared. I think that might help. I think question mark.
Yes. Jeff Herman with the pencil. So far I have drafted 3 versions for you between last year, the bill is introduced and the amendment. Is there any of that? How does that, any of that relate to what you actually want?
Here's
To
here's
go
my
back to this.
suggestion, we have 3 different drafts now.
Well, I mean, I'm looking at the existing law
Existing
being
law.
passed last year, bill as introduced,
Yes, okay,
the strike all amendment that
yeah, that we
went
have
into
now.
now.
Draft 1.1.
Yep.
Yeah. Maybe what we do is we give ourselves an opportunity to read this one more time. Think about what we've been discussing, and then we'll come back with some endpoint decisions. Senator, go ahead.
This is a question for you, Madam Chair, which is, number 1, is doing nothing an option? And number 2, if we do nothing, what will the consequences?
We'll have more Rutlands. I mean, the least of that we can do is to have a public hearing and some public process. I think that the hospitals are suggesting and others are, and I see Jill is just dying to speak. Okay.
I apologize.
Please,
My
go ahead.
eyebrows moved, as they do. Jill Olson, I just wanted to clarify one thing. If you do nothing, the existing law remains in place, which is the Green Mountain
Right,
Report.
we
process.
understand. We understand that move,
Yeah.
what the proposal did was to move it from Green Mountain Care Board to AHS, and that's the conundrum. And who has the data and how are the decisions made relative to the budget? We get all that. So now we're gonna go through and we're gonna read what we have. And then we're gonna come back and we'll try to sort out a step forward. We don't wanna, staying the same will result in what we have seen in Rutland when the kid beds were cut. Now, I'm not interested in having the community go through that again. That was deadly to some parents and some kids. Oh, this group right here, we're thinking about this. Okay. All right, so we'll with yes, no.
I'm looking at the bill, which was published the notice in a newspaper for general circulation.
Yeah,
Other than the Burlington Free Press, there is no newspaper of general circulation.
not anymore. We're gonna have
Not
to fix that one. Jen,
I mean, that's
Issue right there.
an issue.
yeah, that's.
We've
an
always said that. but
Yes,
Public notice. Even for local communities.
issue. Right, it was all local and general, I think is what.
Yeah.
Yeah. Everybody who's, the two parties who are interested in this, I understand. Where the problem is, we're gonna solve it.
I understand also, and you're in a moment where public trust is so compromised and so broken, and this, if we don't do anything, it exacerbates the lack of trust the public has in all of these entities and all of these institutions. And to your point, we are the Health and Welfare Committee. We are responsible for the health and welfare of Vermonters. And it's really important that we act and do something to protect people.
You're with it. I'm with you. Yeah, it's well taken.
I'm looking at the highlighted and struck out and.
Oh, yeah, there's a lot going on.
Well, this is exactly why.
The highlights and struck out.
I'm on
Yeah.
1.1.
Can we go
Yeah.
through 1.1 briefly so we know what we're thinking about?
What is
And we have,
Sure, but to be clear, I think 1.1 is maybe the AHS compromise proposal. Is that
It was.
accurate?
yeah, it's fun to look at.
Okay.
It might be an interim step. This is the thing I'm thinking about. That might work out.
So this is S189 draft 1.1. So strike all, but the highlighting is showing you what's changed from the bill as introduced. This would create a section in Title 18 on hospital service reductions, but requiring notice, not approval. So it strikes out language from the bill as introduced that would say a hospital shall not reduce or eliminate any service without approval from the Secretary of Human Services. It would require a hospital that proposes to reduce or eliminate any service to provide a notice of intent to the Agency of Human Services, Green Mountain Care Board, Office of the Health Care Advocate, and the legislators from the hospital service area. I know there've been some discussion when we walked through this before about maybe adding some legislative committees. At not less than 60 days prior to the proposed reduction or elimination. That notice would explain the rationale for the proposed reduction or elimination, describe how it's consistent with the statewide healthcare delivery strategic plan once established, and the hospital's most recent community health needs assessment conducted pursuant to state and federal law.
And then before you scoot ahead,
Yes,
I'm looking at the word any, for service.
yes, I mean, it was, and I do too.
Well, no, I'm thinking any service. And so what does that mean exactly?
Well, I know you've heard some discussion, I think, about what level of reductions should trigger process. I know eliminations, I think, seemed easier, reductions. I've heard concerns about what happens if a provider leaves,
Right.
provider group. Is that a reduction if you have less availability? Does that need to go through this process?
That was one of the reasons the psychiatric policy, that was so because the provider. Right, yeah. Okay.
But could provider no service? Could service include like IT services or phone services, or is it just?
I think that was I think it was a clinical service.
That was not the intent, but
Yeah.
could it possibly?
Right.
Okay.
I mean, we could certainly have a modifier.
It's service to the public. So unless they're providing.
Right, it's really a medical or healthcare service, but we can provide.
I think just say something. I feel like the girl who kept the words.
Okay. Okay, so some options for that. So this is to provide notice, post the notice of intent on the hospital's website on or before the day on which the notice is provided under subdivision 1. Publish the notice in a newspaper of general circulation in the hospital service area. So it's not necessarily statewide, but this has been part of our notice process in the past. I don't know if it makes sense anymore or not. But it seemed better than saying, put it in front porch forum or something. I mean,
Well, we
might
could say in various media,
It's not news.
Does every part of the state have a local paper?
I think most of them have like a local volunteer. But
Yeah, there's a, we can certainly modify that. I don't think that's the sticking point on.
No, no.
But it is that the world is changing and we haven't changed our standards.
Right, right.
All right, conduct a public engagement process, including holding one or more public hearings in the county in which the hospital is located and soliciting and responding to public comments regarding the proposed service reduction or elimination. The public engagement process can start before the notice goes out, but must continue for not less than 30 days after the notice. And these are all just, placeholder dates and times, and everything. The hospital shall provide a summary of the community's response to the proposal, including the public comments received to the Agency of Human Services. And this would change from weekly during the public engagement process and bill as introduced to following the conclusion of the public engagement process. So strike the language about the Agency of Human Services reviewing the proposal, considering the impact of the proposal and approving if the agency determines it's not consistent with the statewide strategic plan, community health needs assessment, doesn't unduly burden access to care and services, and the pros outweigh the cons. So that whole AHS approval piece comes out in this draft. And then, yes.
Right, so that all comes out. My suggestions is we leave it in and it goes into place after the plan is in place. And all the other things that we're talking about, we do in a preliminary way, we do this stuff in the intro. That's what I'm talking about, so that there's some pressure on everyone to work together and make decisions. And I'm very clear, I'll be open about that.
The late effective date of AHS approval.
Comes out with the-
Yeah, the word
Yes,
recommendation.
Making a recommendation
Yeah.
to.
Right, and there was talk last time we went through this about a recommendation rather than approval. So I don't know if that's where and I don't know if you were thinking recommendation in combination with the delayed effective date for this piece, or recommendation until the plan and then approval.
In the interim, it's gonna have to be a collaborative process. I do think, unless I hear differently, but recommendation would go in.
Recommendation go at what? Huh? I didn't.
You didn't understand.
I didn't understand.
In the interim, I think we have the public notice and we have some communication between AHS and the board about what's happening in the transformation process. At the end of the line, after promulgation, then this stuff goes into place with the word recommendation.
Recommendation instead of,
Yeah, otherwise,
okay. So when this information in the shorter term, when this information is, if the hospital is providing a summary, this is where you want AHS and the board to be
somehow sharing. This is what we haven't heard anything about. That could come from AHS. Wow, this is brand new to us. Or golly, Ned, we've been working on this and it makes some sense, and they can communicate as much as they can tolerate.
Okay. So then recommendation with the latest date. Okay. And then in this version, so if the agency approves the service reduction, that would come out because there's no approval. I think that still carries through in your revised version. But if a hospital elects to proceed with reducing or eliminating the service after completing the process, then they have to notify the board within 5 business days following the hospital's decision to reduce or eliminate the service, so the board can review the impact on the hospital's budget.
And
It
I
goes
think,
into hospital
I
budget.
think what we want is notification to both the board and AHS, right?
It's on.
Oh, yeah.
Isn't it in there?
Is it in there?
Well, in this specific piece, I mean, the agency is providing a recommendation, but, but I think, yeah, I would notify, this just says the board, but we could certainly add AHS and then be clear that it's, and maybe that also we could tie into notifying AHS to inform its work on this, ongoing work on the strategic plan and the board, so it can evaluate for the impact on the hospital budget.
Yeah, I mean, it does make sense if the board might be considering a CON from somewhere else within the region, you don't know.
That's interesting. Could the say it was too expensive to provide a certain service at one hospital. And they want to get rid of it anyways, the hospital does. And move it to another location that seems to fit the community better, whatever like that.
Yeah.
Would the Green Mountain Care Board be able to force a certificate of need to that hospital for a certain type of service?
I don't think so. That's not.
If it, I mean, if a hospital is planning to stand out of a service.
Yeah.
And it triggers the jurisdictional thresholds in the certificate of need law, then yes, they would require a certificate. I mean, the Green Mountain Care Board wouldn't be forcing it, it would just be by operation of the existing CON law.
Okay.
But the triggers were increased fairly significantly.
Yeah, we did that last year.
Okay.
We increased.
And does that sound, that's true.
Okay, thank you.
I can tell them if it is.
No, that's okay.
That's a good question.
All right.
Keep going. All right, so we can work on some language there, and then the Green Mountain Care Board, so this would take out the existing law process that was established in Act 68, and instead change this to upon receipt of notification, and then it's not coming from the agency of human services, it's coming from the hospital, that the hospital intends to reduce or eliminate service after completing the process. Then the board reviews the impact on the hospital's approved budget and can adjust the hospital's budget as necessary. Which may include directing any savings related to the reduction or elimination or return to payers and Vermonters to address affordability concerns or reinvested in primary care prevention and other community-based services. And then just modifying language a little bit around board's collaboration with DFR and the monitoring the implementation. And that's it.
Jerry, something that was. So you say, we don't do this, you think we're gonna have more problems. With the Rutland experience. I'm not sure you'd have the same problem.
You're not sure what?
I'm not sure you'd have the same impacts as Rutland.
Oh.
Down. So my only question is, right, this, because of all the flux of where we are and the transformation, all that stuff, no, this bill's really needed. I hate to say that. There's got to be a process now that's kind of in place. Without this bill, I don't know what it is. I don't know. What
No, it's the only process in place, this underlying statute, which resulted in Rutland. There is no public hearing required. There is no public notice required.
All right.
The transformation plan doesn't have an effect unless it's a willing player. So do nothing.
No, so
I'm not,
because I am for the public process.
yeah, no, understood that the goal, what I'm thinking of is putting the public process in that would ameliorate some of the problems that we see. In the meantime, AHS is working exceedingly hard on collecting data, working with, doing transformation, helping the community. And once that gets in place, there might be a firmer understanding of what's there, what's not there, and what would influence the budget. That's why I say, put it out there, but let's put something in that helps. So it'll be reassuring, I think.
Yes.
One option would be, don't look at the longer term plan, and just do the immediate plan.
Right, and that will never change, because you'll come back in 3 or 4 years and no one's gonna it'll be the same battles, all of
Very true. Yeah, I
I'm-
think you
The only difference is we'll know more about what the strategic.
And we
plan
will,
is.
and within this time frame, we ask for information and about how to improve this process. We do exactly that.
All right, so I feel like I have enough, enough guidance to get you a new draft on this.
Glad you do. That's
Um,
good.
well, if you know.
Yeah, no, I
we'll see.
think we're good.
Although I do think, there are a couple things to think about around whether you want to put some parameters on what a reduction is that would trigger this requirement.
Yeah,
Um,
I agree with that one.
and if you want to do something about the newspaper based.
Media, regional media.
Um,
That'll be our last.
Yeah, what is the reduction?
Well, the size of the service reduction, I think, and the type is really,
Yeah.
oh, wow, it's gonna be important.
yeah, and I don't know if that's something that, the hospitals can help us think through. I know that had
Yeah.
examples in the past of like,
Right.
what if somebody retires? Do we have that? And it reduces services that, and I don't think that's what you want, but are there particular sort of lines you can draw around what it means to sort of significantly or reduce the service? So I don't know if I can
Maybe AHS can help with that.
Yeah.
Hospitals can help.
help me think through that one.
Careful with the answer to that. But that'd be good.
Thank you.
Okay,
Okay,
this has been fun.
what's next?
Okay, what's next? What bill are we doing
190
yesterday?
or 197?
We were doing 190.
We were doing one thing.
We were doing 190. So let's go back to that.
Okay.
Okay, thank you for that work. That's difficult, right?
Right.
All right, so next up we have S-190.
Do we have?
Nothing. Nope.
Yep. Got
We've started a little bit to talk about, but you've gotten testimony from a variety of people. So this is Green Mountain Care Board, reference-based pricing, hospital outsourcing of clinical care. We've had some proposals around on the board around reference-based pricing. You have some proposals from the hospitals. Great job of remembering who else you heard from.
Oh, we heard from insurance companies, and we heard from the board. We heard from-
Right, but as far as what proposals you have heard that you are interested in?
Oh, on reference-based pricing, I think we were thinking about, looking at high cost,
Yep.
that, information.
Yeah,
We were also,
so the Green Mountain Care Board's proposals.
yeah, but thinking about it, right?
Yep.
Not interested in diving into specific services necessarily. Like the insurance companies brought up laboratory and others, and
Oh, right, yeah.
not our job,
Very different.
not our job.
Yeah, and I think, in
And the
the
other thing-
language, it may flag some of the same services the hospitals we're talking about without being.
One of the things that's come up from time to time with this is different hospital size. And so the academic medical centers versus critical access versus maybe our larger hospitals, and whether there's a differential to be in place, depending on the hospital organization. Or is that that's something that the board should be charged with evaluating in the reference-based pricing flow.
I can't remember the difference between critical access hospital and hospital.
Critical Access Hospital is a subset of hospitals, but I would love to let.
Oh, we
Devin
have the
explain
hospital. There are different, six of them. I could see them lined up, but I can't.
Yeah, actually, we have 8 of them. Devon Green, Vermont Association of Hospitals and Health Systems. We have 8 critical access hospitals. They're a federal designation for purposes of Medicare payment. You have to have fewer than 25 beds and sort of like a geographic component in terms of this.
That's critical. Okay.
Yeah. So it's all about
So much.
creating access. Yes, yes,
Yeah.
yeah, critical access hospital.
And then we have larger hospitals. Can you speak to that?
Yes, the larger hospitals are, they're another Medicare designation, but I would say we have Rutland Regional Medical Center, UVMMC, CPMC, Southwestern Vermont Medical Center. Brattleboro Memorial Hospital is a little funky.
It's now a critical access.
Well,
Medicare
actually,
Independent Hospital.
and it's participating in a federal model that sort of allows
Yeah.
it to be paid like a critical access hospital, but it's not.
It's not quite a critical access.
It's funky. It's
Yeah.
definitely
But you get the drift, but the academic medical center is a separate category all by
Yeah,
itself.
that's a tertiary care
Yeah.
hospital, so that's major trauma, and then it's also an academic medical center, so it's a teaching hospital.
And it gets a higher insurance reimbursement because it is an academic.
Right. And so there's all of those things to
So
consider.
not even Medicare, not even Medicare is the same, then going to hospital.
Correct.
Right.
Oh my lord.
And they get facility fees type reimbursements to support their facilities at different levels. And it's complicated.
Set forth at CBH, I pay a $200 facilities fee to UVMs,
So, which is why,
and they're buying up,
there are differentials across the world.
they're buying up a lot.
What's Porter? Porter?
We're just
Porter-
critical access
Yeah,
hospital.
And Porter critical access. Copley is
Critical access.
critical access. Southwest is, I call it regular.
Yes, Northwestern,
Rutland, Northwest,
Northwest is regular,
right? What about St. Johnsbury?
critical access.
Critical access, Northeast Kingdom,
All
critical
critical
access. so all of that, they're all critical access.
So they're different Medicare and Medicaid rates? Or just
Medicare,
just Medicare?
as far as we know.
Well,
I don't know how
Medicaid is-
Medicaid
Medicaid is
determines
their
this.
price. Yeah.
I just wondered because there's federal dollars associated with Medicare. I didn't know.
Yeah, it's through the state.
Yeah.
Ryan, 190, the one we're talking about reference based price.
It's
We have some regular hospitals, some critical access and one funky.
Oh, which one's the bumpy one?
Ground. It's just more complicated.
Okay. So let's just go through 190 and we'll identify some places where we have decision points to be made. One of them was the reference based pricing on high cost, high utilization. We also were talking about differential pricing based on type of hospital.
Yeah, and I mean, I think that may be inherent in the existing reference-based pricing language.
That's what I was wondering. I think it is. Yeah, it is.
I don't know if that.
Thank heavens for that.
You had the request from the hospital association to delay the NPI, separate NPI for off-campus services to align with federal timing.
So it's in the bill as a 26.
It's in the bill as October 1st, 2026, and the hospital association would ask for January 1st, 2028.
What was the board response to that?
But there's also a but.
Devon Green was, when we talked with the insurers, they said October 1st, 2027 would be optimal, and we're amenable to that. We could do that.
Okay,
Perfect.
so let's decide on that.
Yeah.
Good.
Can't believe it.
We did something.
Something good.
Be better than that.
Oh, you've been at, it is time for spring break.
So the Hospital Association also asked for language in C here to have the Green Mountain Care Board expressing rates for items and services and its percentage of Medicare. I'm not entirely sure I understand this request since it's
What's the
provider,
request?
it's provider contract, so it's like hospitals and insurers.
Oh, they make the contracts first and then,
I don't know how the boss sees that playing out, so.
Yeah.
Go on, Fred.
Having Green Vermont Association of Hospitals and Health Systems, I think where we were at with that, it's the Green Mountain Care Board gets our prices anyway. And my understanding is from legislation last year, I could be wrong on the contracts piece, but that they do get our prices. We're concerned, it's not easy to do the calculation of the percentage of Medicare. There's a lot of factors that can come into play. We've often heard the Green Mountain Care Board express frustration around us not having our budgets standardized as much as they could be. And we're worried that we're going down the path of people calculating things slightly differently. We don't understand why it's hospitals doing the calculation and not the Green Mountain Care Board doing the calculation.
okay, so what line is that?
We're literally on C here, so it's hard with it because it goes across 2 pages, but for provider contracts entered into on or after October 1st, 2026. And the bill is introduced says each hospital and health insurer shall express the rates for all items and services as a percentage of Medicare or another benchmark if they're going to determine. And so I think what you're hearing from the hospitals is we are not sure we're all going to be using the same calculation
I think,
for Medicare
yeah,
rates. So please don't put this on us.
Sure.
And my question is, how is the board isn't involved in the provider contract till afterwards, so I'm not sure if the request is.
they don't know all the thousand.
Translate.
Okay,
So
Okay.
I'm not sure, what you want to do.
I see 2 things in this. 200 things in this? I've just got knocked out of my head. Let me just go back again. The board should be establishing reference-based pricing based on service and certain codes. That's the board's job. And the hospitals then use that in the rate setting. I don't know why this is happening through contracts at all. And can I get clarification? The board has response, I think. I don't understand that. Okay, well, how do you get that? Well, I mean, I
And
understand.
my sort of general read on this is the board would like things to start to be expressed as percentages of Medicare.
Yeah,
So that
that's-
everybody is
okay.
using the same.
That was exactly what I was going to. Oh, thank you. You brought it back to my mind. Go ahead. Say it again.
Say Diane Lake for
Go ahead.
Green Mountain Care Board, in preparation for and the continuation of work for the reference-based pricing, we're gonna need to have the data expressed in the,
Where they currently are.
Right.
So we need to know that it's 500% over or 200% or whatever. Okay, thank you. That's good. Now, why do we need to invoke? Why do we need to, I gotcha. Why do we need to invoke provider contracts in that? Why can't we simply say hospital and insurers shall express? So why do we put the contracts in the middle of it? The contracts are the contracts between the 2 entities. They are supposed to be they are transparent, but what we're trying to see is just what's the bottom line. Am I missing a point?
I think you're right, Madam. Like, we wanna see what the bottom line is, not just what it might be, but what is it in the actuality of the contract.
I'm done with the hospitals say, just like everybody kind of classifies things in their budget slightly differently. That they calculate Medicare, those payments slightly differently, or is it just you've got 3 services being delivered to one person at the same time, you've got a bulk rate. And you've got to divide it out. Is that,
Yeah, Devin Green from Buzz. So it's, what we're hearing from our chief financial officers is that we're not sure what the methodology is yet. And so we don't want to be in a position where everyone's,
Right.
applying it differently and we're getting different answers. We want it to be uniform. We want one source of truth. And then B, this is actually administratively burdensome for us to do. This is a difficult task. And so we're not quite sure how to do it, and we think it will take resources.
good question. So what do we want to know?
It would take, if it's difficult for one hospital within their own system, which I would defer that it might be. I don't know that for sure, but I can't imagine how much more difficult it would be for us to do 14 of them without the insight of that a hospital would have on its own system. Be able
Maybe,
to calculate all their prices.
so maybe because reference-based pricing isn't going to go in all at once. Maybe the board requests of the hospitals specific Medicare related services as a percentage of Medicare. Maybe we put in that the board will ask for specific services within the over time, within a specified period of time. So the board could ask for all orthopedic services and all pediatric services. I'm hypothesizing. I'm not saying which services, but that's something between the board and the hospitals. And then then those things could be broken out on a gradual basis. Yes, it's administratively burdensome, but I agree with the board. Doing 14 of those all at once is massive. Yeah.
Devin Green from Buzz. The board has received funding to do this work, though, and physicians to do this work, and hospitals have not.
So the board could work with hospitals to do that.
I would have.
That's what we're saying.
I would
Okay.
have to
So
check
now
see
we
what
said the board can work with the hospitals to do selected services. And the hospitals will provide needed information. I don't. Act 68 collaboration. But so. How does that make sense or not? I see a yes from the board.
I would say that we would probably need to go back to, I'd have to go back and find out.
Yeah.
What the problem would be or what our reaction would be to that.
Okay.
And just, sorry, one more.
Yeah, go ahead.
So Devin Green from Buzz, we sort of ran into this already with the prescription drug price cap and how we were supposed to implement that. And we asked the board for just post the price. And we did not get that response. And so we would really appreciate in this moment of transition one source of truth that's standardized, clear, easy for us to follow, as opposed to 14 different calculations. Or
What would you say?
I would say that the board could do these calculations. And we are happy to post those. We understand the transparency aspect and wanting those prices posted. We are happy to be transparent. We're happy to give them the data. They already have the data. We're just not sure why they can't do the calculations.
And I would say we haven't done an analysis on what it would take to be able to do that. So we don't have an answer to say, if we did do that, how many man hours and what information? So we would need to be able to figure that out first before we could even decide.
Okay, but you have a provision in here that I think came from the board in the first place that is putting administrative burden all over the place. So we need some language here that will have some graded response and collaborative work together we've put a lot of money into the board for the work, right? You know that, and positions, so, okay, all right, so Jen, you
Put a
get.
question mark next to the section.
No, but not really. It is the work of the board with the hospitals to make sure this happens and maybe to identifying specific services. And they need to accomplish reference-based pricing. And global budgeting will be coming up very soon, so there's a time frame in here. We always forget the time, but there's a time frame in here. Okay, now we're not dropping global budgeting. We want to do that first. Let's work on reference-based pricing too. Okay,
So are you wanting, first of all, are you wanting this provision to take effect for contracts entered into on or after October 1st of this year? And if so, do you want, or in any event, do you want to say that hospitals and health insurers will express the rates percentage of Medicare based on information received from the board or something?
something about the work between the board and the hospitals to categorize specific services as a percentage of Medicare, and that the board shall identify those services, and so there's a framework for them to look at just a few services.
To be.
Okay, that's different than express the rates for all items and services.
Right.
Yeah, well, ultimately, it's all items and services by such and such date. What date do we put in there? I'll leave it at 26. I'm happy leaving it at 26. It sounds like a Herculean task by 26,
That's what I keep.
but I'll just leave it. Let's leave it.
Because I think what I heard is that the responsibility for developing the actual rates would lie with the board through consultation with the insurers and the hospitals. Right?
Yeah, we want to know what the bottom line is. What's the payment model for what is the hospital being paid for that services? If it's bundled with x-rays and labs and everything else, you pull it out and you look at those costs, and that's the hard part right there.
So is part of the issue that the board needs to develop sort of a master list of Medicare benchmarks so that everybody can do the math?
I'm trying to figure that out too. What would happen if you did it by bundles? I mean, board, what would happen if you did it by bundles? I know. And then they've also got those great big bubbles out there with labs, and they're gonna have to sort that out at some point. But if they did it by bundles for knee replacement surgery or cardiac surgery, or I need an answer from the board, so we'll have to talk on this.
Well, I think that's one more.
Yeah, oh, yeah.
And that is looking at that date. I guess I'm looking at the two groups right here that are responsible for actually developing this. And is that really a realistic date? Or should that be further out? And if we do it in steps, so we understand how does this really work? And if we go to reference-based pricing instead of it all happening at once, happens over a period, we can see where we made our mistakes and have time to correct those.
But Senator Benson, I will tell you that we've been talking about and working on reference-based pricing now for quite a bit of time. Asking for that date out there is an extension of a problem that we've been facing. And they've been working on it. So right now, unless I hear compelling information, we haven't heard from the board. We're hearing something from the hospitals. I'm not leaving the date, and then we'll sort it out.
And I'm putting some potential notes in here like they shall begin expressing as a percentage of Medicare based on a collaborative effort between the hospitals
There
and
you
the
go.
board to determine sort of which items and services
Right.
and how.
I mean, it could be bundled, you know, that might ameliorate some of the difficulty.
But yes, but I think that only works if the services are delivered in with that.
The same way, exactly.
And I get statement every month, couple months from Medicare telling me what I was charged and what they paid.
Yes.
For what service, and I get another one from my Medicare supplement. So somebody's breaking
Bring it down.
it down.
Right, I mean, I think that the insurers know what
Yeah.
they've paid. They send you an explanation of benefits as well. I think it's just a matter of getting everybody using the same Medicare, Medicare definitions, including modifiers and,
Gotta align all of this.
They aren't,
Alignment.
Medicare has modifiers. It isn't.
well, I don't, honestly, I don't know enough about Medicare, but I know I know there are lots of variables that and I think even in some of the language that the board provided, they're talking about the like Medicare adjusted base rate. Which is, has its own.
Right.
Right.
But you can't make things.
So just to give, based on the definition, I think this may help just to understand the different variables that are involved based on the board's proposed language. They define Medicare and their what they submitted as testimony. Medicare adjusted base rate means the standardized Medicare payment amount for hospital inpatient, outpatient, or professional service as determined under the traditional Medicare program, calculated prior to the application of any hospital-specific, patient-specific, or policy-based payment adjustments, reflecting only the core payment methodology used by the Centers for Medicare and Medicaid Services to establish baseline payment levels, including adjustments for geographic factors such as wages. And then some additional stuff for critical access hospitals. So that's why you can't just say, the Medicare rate.
I'm there in sympathy for hospitals.
Oh, yeah, where are we? We got another big.
I think we can potentially call ourselves through reference-based pricing for the moment, based on, I'll make the changes from the
Okay,
board's proposals and some of what you've decided so far. Hospital outsourcing.
so
There we
are. We've taken testimony on it. We'll look at that testimony. Maybe we can put something together for post-town meeting to look at. And so we have a little comparison.
We were thinking about a study for that, weren't we?
I think you were talking about reporting,
Yeah.
some reporting.
We got conflicting information.
You did, yeah.
And then
So-
there's
Like information.
I had a
different,
lot.
you can outsource, some people outsource all their lab work, some of them may outsource a specific kind of lab work. I think when we were doing COVID, there was a problem in a Massachusetts lab and none of the tests came back. And it's kind of, I think it was Cigna that said, if you outsource like to one person, but if you outsource whole departments, emergency rooms need to be, there's private businesses coming in. I was when Springfield was going belly up. All their emergency room doctors came from a company in Chester, Vermont. So I assume they have an office there somewhere, but that was a whole department that was outsourced. And radiology is another one that, at least nationally, gets outsourced.
Right, I think labs and imaging, radiology. There's a lot of outsourcing, and then what was getting explored more recently was the direct patient care, the emergency department, anesthesia.
We're also hearing conflicting thoughts on private equity.
Yep.
So it'd be nice to have some more clarity in that.
Then 5 years ago.
So going back, we're thinking about having some data brought, some information brought back to us on this. That would. More clarity.
Trying to remember what you had people. So I think VAS and VM and the Medical Society had recommended, replacing the language in the bill with, a requirement that the board require reporting on outsourced services for next year's hospital for FY 27 hospital budget, so the ones that will be submitted for.
So then you'll get the information.
October. And
That
then,
makes,
and
that
then,
makes sense.
and then the board could make some recommendation after contracting with hospitals and their contracted providers. Assessing impacts on access, quality, and affordability, the board can make recommendations to the legislature by next January.
That I think was good. That solves us.
All right, so,
Well, the board was,
Thank you.
supports the language as it was written. I know
Yeah.
that.
yeah,
Oh,
Yeah.
okay.
Yeah. It's okay. I know everyone is, you want to do what you can out here, but you know that
You've got
takes steps to get there.
so that, you did take care of several pages.
But I'm going to suggest, what page are we on?
No, I'm getting there.
Yes.
And then, I mean, there is some,
Our financial assistance.
Money watcher is,
Huh?
we might want to put some, request in here that they report any impact on provider taxes. That's.
Oh, bless your heart.
concern.
Yes, thank you, Nolan. Thank you.
Reporting it out.
Coming.
Yeah, because that will impact our ability to pay Medicaid bill.
What page are we on? Because we're gonna end right here.
Just a report back, so you want to.
Yeah, but-
right, so is that what the hospitals are telling the board, or what the board is telling the legislature, or both?
Board, should come to legislature.
Yeah, we'll have to
So they have to consult.
consult with the AHS.
Yeah, HS.
So then we're up to the healthcare professional bargaining group.
Yes, and I think what the BMS had requested was appropriate.
So carve out the reference-based pricing, is
Yeah.
that the
Yeah,
BMS proposal?
yeah, well, we can look at that with everything else.
Okay.
And then. What?
Just
Telling me we have something.
I don't remember.
Payment amounts methods.
Hospital, oh, yeah, the section review.
Can we end, then it should repeal.
That's the bargaining group stuff. So
Yeah.
then it's the Granite Board Appeals.
Yeah. Let's end here.
Okay.
That's less complicated. And we're gonna take a break, and our brains have done good work. Well, this is great. This is a good way to get this done. So we have more.